Let's unpack this a bit. You might be thinking, why on earth do we need so many different ways to check for blood sugar?
It does seem like a lot, doesn't it?
Yeah, it seems like there's this whole diagnostic toolkit just for this one aspect of our health. What's the rationale? Why not just one test?
It's a really great question, and the answer truly lies in the dynamic and, frankly, complex nature of glucose metabolism.
It fluctuates a lot.
Constantly. Blood sugar levels are always changing, influenced by everything from the food you just ate to your stress levels, exercise, time of day.
Okay.
So each test gives us a slightly different piece of the puzzle, a specific snapshot in time, or maybe a longer-term view. They help us screen quickly, diagnose accurately, or monitor how things are changing over time.
Different tools for different jobs.
Exactly. Each one has a unique role, and using them together gives us a much more comprehensive picture than any single test ever could.
Makes sense. Okay, let's walk through them. What's the quickest check?
The quickest check is probably the random blood sugar, or RBS.
Random, like any time.
Exactly what it sounds like.
Okay.
A blood glucose measurement, take it at any time, no need to fast or anything.
Okay, what's it good for?
Its purpose is primarily for general screening or maybe in emergency situations where you need a really rapid assessment.
Got it. And what numbers are we looking for?
Well, if your RBS is over 200 milli-GDL, especially if you're also having symptoms like that excessive thirst or urination we talked about,
Yeah.
that's a strong indicator of diabetes and usually means more investigation is needed.
And low.
Conversely, an RBS below 70 milli-GDL would likely indicate hypoglycemia.
Okay, so RBS is the quick snapshot. What's next?
Moving to a more baseline measurement, we have the fasting blood sugar, or FBS.
Fasting. Okay, this requires prep.
It does. This is a primary test for diagnosing both diabetes mellitus and hypoglycemia, and the preparation is key. You need to fast for at least 8 hours. Only water is allowed.
8 hours, water only.
Right. And you should try to avoid any strenuous exercise or acute stress right beforehand, as that can affect the result.
Good to know. So what are normal fasting levels?
For adults, normal fasting levels generally fall somewhere between 70 and 110 milli-GDL. Different labs might have slightly different ranges, but that's the ballpark.
Okay. And for diagnosis?
If your fasting plasma glucose is 126 mg/dL or greater on at least 2 separate occasions.
2 times.
Yes, confirmation is important. That's considered diagnostic for diabetes mellitus.
And what about prediabetes?
For prediabetes, or what we call impaired fasting glucose, IFG, the range is 100 to 125 mg/dL.
So FBS gives us that baseline when the body isn't processing food.
Exactly. A clear picture of your underlying glucose control.
Okay, what about after eating?
That brings us to the postprandial blood sugar, or PPBS, often called the 2-hour postprandial glucose, or 2-hour PPG.
Postprandial, after meal.
Correct. This test assesses your body's insulin function after you've eaten a meal. Normally, insulin quickly brings glucose levels back down to near the pre-meal range within about 2 hours.
Okay.
In diabetes, though, those levels stay elevated, showing that the quick response system isn't working right.
So it tests the response.
Precisely. It's a great tool for monitoring treatment effectiveness and can also be used in diagnosing gestational diabetes.
Has it done?
For this test, you'll typically eat a standard meal containing at least 75 grams of carbohydrates, and then your blood is drawn exactly 2 hours later. No snacking or extra drinks in between.
Got it. And the numbers?
A value of 200 milli-GDL or greater 2 hours after that glucose load is diagnostic for diabetes.
200 again?
Yep. While values between 140 and 200 milli-GDL indicate prediabetes, or what's called impaired glucose tolerance, IGT.
Okay, FBS, PPG. What if those aren't clear enough?
Now, when we need a deeper, more detailed assessment, especially if other tests are maybe borderline or inconclusive, we turn to the oral glucose tolerance test, or OGTT, sometimes just called GTT.
The glucose drink test.
That's the one, the sugary drink. It evaluates how well your body handles a sudden, large dose of glucose.
Why do this one?
It's often used for screening for prediabetes or gestational diabetes, especially when risk factors are present, like a family history of diabetes or obesity.
Okay. More prep involved.
Definitely. Preparation is crucial. You'll usually need a consistent carbohydrate intake for a few days prior, followed by an 8-12 hour fast, water only again.
Right.
Then, after an initial fasting blood sample, you ingest that sweet glucose solution, usually 75 grams.
Chug it down.
Pretty much, within about 5 minutes. Then subsequent blood samples are taken at precise intervals over typically 2, sometimes 3 hours.
Okay. What tells you diabetes here?
For diagnosis, a 2-hour plasma glucose level of 200 milli-GDL or greater after drinking the glucose load is diagnostic for diabetes. Again, confirmation is usually needed.
And prediabetes on the OGTT.
Values between 140 and 200 milli-GDL at the 2-hour mark indicate impaired glucose tolerance, or IGT, which is a form of prediabetes.
Okay, so OGTT is the challenge test. Is there anything specific just for pregnancy?
Yes, absolutely. For pregnancy, we often start with the O'Sullivan test.
Oh, Sullivan. That's just a screen.
Primarily, yes. It's mainly a screening tool for gestational diabetes mellitus, GDM. It's usually performed between 24 and 28 weeks of gestation, or maybe earlier if there are high-risk factors.
How does it work? Simpler.
It is simpler than a full OGTT. You're given a 50-gram oral glucose load, less sugar than the diagnostic OGTT, and then your blood glucose level is measured just 1 hour later.
Only 1 hour.
Right. If that 1 hour reading is 140 mg/dL or greater, it usually means further evaluation with a more comprehensive 3-hour OGTT is warranted for a definitive diagnosis. It acts as an important first filter during pregnancy.
Got it. Screen first, then maybe the full OGTT if needed. Now, I've heard of C-peptide. What's that about?
C-peptide, or connecting peptide. This is a fascinating one. It's an inactive amino acid byproduct that's released when proinsulin is converted into insulin inside your pancreatic beta cells.
A byproduct of making insulin.
Exactly. And crucially, it's released in amounts similar to your endogenous or your body's own natural insulin.
Okay. Why is that important?
Because its levels are not affected by any injected insulin someone might be taking.
So it measures natural insulin production.
Precisely. This makes it a vital biomarker for assessing your own insulin production. It's particularly useful for differentiating between type 1 diabetes, where C-peptide levels will be low or even absent because the beta cells are destroyed.
Right. No factory, no byproduct.
And type 2 diabetes, where C-peptide levels are often normal or even higher, especially early on, reflecting the body's struggle with insulin resistance. It helps us understand if the insulin factory isn't working, or if the body just isn't responding well to the insulin being made.
That's really clever. Okay, one more big one. HbA1c.
Yes, glycosylated hemoglobin, or HbA1c. This test truly is a game changer for diabetes management.
Why is it so important?
It's formed when blood glucose binds irreversibly to hemoglobin within your red blood cells.
Sticks to the red blood cells.
Yes, non-enzymatically. And since red blood cells live for about 120 days.
3 to 4 months.
Exactly. The HbA1c test gives us an average blood glucose level over the previous 3 to 4 months.
An average, not just a snapshot.
Exactly. Think of it like a tiny historian in your bloodstream, recording the average sugar levels over a sustained period. This makes it a powerhouse test for diagnosing diabetes, monitoring how well treatment is working, and assessing patient compliance.
And it's not affected by what you just ate.
Correct. It's unaffected by short-term variations like recent meals or exercise or acute stress, making it a really reliable long-term indicator.
So what are the numbers for A1C?
The normal range for HbA1c is generally considered to be below 5.7%.
Okay.
If you're in the prediabetes range, you'll see levels between 5.7% and 6.4%. This indicates an increased risk for developing diabetes.
And diabetes itself?
A level of 6.5% or higher is diagnostic for diabetes.
6.5 or more.
Yep. And for most diabetic patients already diagnosed, the American Diabetes Association recommends a target of keeping the HbA1c below 7%.
Why below 7?
Because we know that the risk of complications rises significantly with increasing HbA1c levels. Keeping it below 7% generally indicates good long-term control.
Got it. And do you need to fast for A1C?
Generally, no. That's another big advantage. Fasting is usually not required, which adds to its convenience and why it's used so widely. It provides that essential long-term trend, perfectly complementing the snapshot views we get from the other glucose tests.
Okay, that makes a lot of sense why there are so many tests now. Each tells a different part of the story.
So you might be asking, okay, we've talked a lot about glucose. What does all this have to do with something like the thyroid or the adrenal glands?
Yeah, it's a very valid question. How do we bridge from blood sugar to these other glands?
Well, this is where we really start to see the bigger picture, the interconnectedness of our internal systems.
And this is where we really unlock some profound insights. It all ties back to the incredibly intricate endocrine system.
Exactly.
Diabetes, at its core, is a disorder of endocrine function, isn't it? Because insulin is a hormone.
Absolutely. Insulin is a hormone produced by the pancreas, which itself is an endocrine gland, or at least has endocrine functions.
Right. So it makes perfect sense to broaden our deep dive now into these other vital players in the endocrine system. Endocrine glands are essentially the organs that produce and secrete hormones, those sophisticated chemical messengers we've been discussing.
The message senders.
And they're absolutely crucial for maintaining homeostasis, that stable, balanced internal environment our body is always striving for, and for coordinating physiological processes throughout our entire being.
And we have many of these chemical maestros in our body, each conducting its own vital section of our internal orchestras, so to speak.
Like different sections of an orchestra?
Yeah. For example, your adrenal glands. They produce hormones like cortisol, which manages stress and metabolism, and aldosterone, which regulates sodium and water balance. They also produce epinephrine, that familiar fight or flight hormone. Then there's the pituitary gland, often called the master gland, because it secretes hormones that control so many other glands and processes, from growth to thyroid function.
The conductor of the conductors.
Kind of, yeah. Of course, the pancreas, as we discussed, contains the islet cells that produce glucagon and insulin. And for reproductive health, the ovaries produce estrogens and progesterone, while the testes produce testosterone.
So many moving parts.
All integral parts of this vast coordinating system working in concert to keep us healthy.
Okay, let's zoom in on one of those key players, the thyroid gland. It's a vital endocrine gland situated right there in the front of your neck, often described as your body's metabolic thermostat, right?
That's a great way to think about it. Its role is absolutely crucial in regulating metabolic processes throughout your body. Sets the pace for how your body uses energy, and it's even essential for normal fetal development.
So super important. How does it regulate metabolism? What hormones does it use?
It does this through the powerful hormones it produces. The principal thyroid hormone is thyroxine, which we call T4. It contains 4 iodine atoms. It's like the main product coming out of the thyroid factory.
T4.
Then there's triiodothyronine, or T3. This one has 3 iodine atoms and is actually much more potent than T4, maybe 4 to 5 times more potent, even though there's less of it circulating.
More potent, but less of it. Interesting.
And most of your active T3 is actually formed when your body's tissues convert T4 into T3. So T4 often acts as a precursor, a prohormone.
Oh, okay. T4 becomes T3.
In many tissues, yes.
Yeah.
And importantly, only the free form of T3 and T4, the part not bound to proteins in the blood, is metabolically active. That's why doctors often measure free T3 or free T4 levels.
Free T3, free T4, makes sense. Is that it? T3 and T4?
There's one more, calcitonin. This hormone is actually secreted by different cells in the thyroid, the C cells. It's released in response to elevated serum calcium levels.
Why calcium triggers it?
Yes. And its job is to help lower calcium and phosphorus levels by affecting their absorption in the gut, decreasing bone resorption, and increasing excretion by the kidneys. It's also quite significant as a marker in diagnosing certain types of thyroid cancer, specifically medullary thyroid cancer.
Okay, T3, T4, calcitonin. Now, how is this all controlled? You mentioned the pituitary earlier.
Right. Here's where the regulation gets really intricate and, frankly, quite brilliant. It forms what we call the hypothalamic pituitary thyroid axis, or HPT axis.
HPT axis. Sounds complex.
It's a classic negative feedback loop, which is actually quite elegant. So your hypothalamus, a part of your brain, releases thyrotropin-releasing hormone, or TRH.
TRH from the hypothalamus.
This TRH signals your pituitary gland, located at the base of your brain, to release thyroid-stimulating hormone, or TSH.
TSH from the pituitary. Okay.
TSH then travels through the bloodstream to your thyroid gland in your neck, stimulating it to produce and release T3 and T4.
So hypothalamus, pituitary, thyroid. TRH, TSH to diet T3, T4.
You got it. But here's the genius part, the negative feedback. When your T3 and T4 levels in the blood get high enough, they signal back to both the hypothalamus and the pituitary to inhibit the release of TRH and TSH.
Ah, so the products turn off the production signal.
Exactly. Could you quickly paint a picture of how those 3 parts talk to each other to keep T3 and T4 balanced?
Yeah, it's like think of it like a perfectly managed factory assembly line. The hypothalamus is the CEO, right? It tells the pituitary, the factory manager, we need thyroid hormones. So the pituitary produces TSH.
Right.
The pituitary manager then tells the thyroid gland, the workers on the line, make T3 and T4. But if the warehouse starts getting full, if T3 and T4 levels, the products, are high, they send a message back up the chain to the CEO and the factory manager saying, hey, slow down production, we've got plenty.
Perfect analogy.
And if T3 and T4 levels are low, the message is the opposite, ramp it up. This creates that precise balance, ensuring your thyroid isn't over or under producing.
Exactly.